In this study, investigators mailed approximately 5,000 confidential questionnaires to the physicians of patients who had died. About 64% were returned. In 2013, they found that about 71% of all deaths in their study population were non-sudden. They were expected and therefore able to have end-of-life decisions and discussions. The number of patients who made end-of-life decisions in 2013 was about 59%, which did increase significantly from 2001. The majority of the cases involved decisions regarding foregoing aggressive treatment at the end of life, or a decision to pursue better patient symptom and pain management. There was also a significant increase in end-of-life continuous deep sedation in this population. This is thought to reflect the increase of specific guidelines in Switzerland surrounding this practice. Physician-assisted suicide rates did increase from 0.3 to 1.1%, while the rates of illegal euthanasia did not significantly change, yet they did remain measurable.
There were several points that were striking. The rate of assisted suicide in Switzerland has nearly quadrupled over that 12-year period to 11 per 1,000 deaths. And the authors also reveal the practice of illegal euthanasia and ending the patient's life without explicit request. Both of these trends showed increases, although subtle. Continuous deep sedation until death rose from 4.7% in 2001 to over 17% in 2013. And some of these cases did not include a discussion or decision on end-of-life treatment. It is well known that the practice of suicide tourism exists in these countries and could account for some of the increase. The incidence of euthanasia and/or the ending of life without explicit consent by the patient is stunning to me. Euthanasia as an option is hard to fathom. Furthermore, these services can be extended to those who do not specifically request it, as well as adolescents and those who are mentally ill. In Switzerland, there are fairly lax requirements. Establishing a physician-patient relationship is not even required for these services. I think the United States can learn what not to do from their practice.
The viewpoint in JAMA Internal Medicine by Dr. Linda Ganzini and Dr. Tony Bach provides a very, very nice summary of the history and the current status of physician-assisted death, not just in the United States, but internationally, with the focus on Europe. In Europe, in striking contrast to Oregon, where use of this option has remained very, very rare, it hasn't been increasing the way people feared. Only 2 or 3 or 4 per thousand actually uses. Rates in Europe have actually been steadily increasing, including in countries where not just assistance with suicide, but actually physician use of active euthanasia, the doctor gives a lethal injection, is a practice. But I think the crucial issue for American doctors and the American public is looking forward. And for me, the real tragedy of the whole death with dignity movement in the United States is that it focuses on legalization or not of assisted suicide, which we know in Oregon, only a few per thousand people really even want. And in the United States, we know that the care of the other 995 or more per thousand falls woefully short of what people would want. So if American doctors and Americans believe people should be taken care of the way they would want up through the end of life, we should all unite, whatever we think of so-called death with dignity, in the 3 things that Dr. Ganzini and Dr. Bach call for. Improving access to palliative care early on for all patients with a serious illness, training of clinicians in the communication skills that help them work with patients to really make sure what patients want is understood and respected, and reporting systems that help us know how to improve those things.